Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Gregory DiFelice, or Dr. D from HSS. Dr. D has a very unique approach to managing ACL injuries, and we're going to dive into that today. He believes in what we call a preservation first approach, and he actually ends up repairing a number of his ACL tears. Now, this has become a topic of controversy as the gold standard for ACL management is reconstruction. But I learned a ton in this episode from Dr. D, and I was fortunate enough to spend a few hours off recording talking with Dr. D, and I'm currently rehabbing a ACL repair, and I've got to say, I think Dr. D is really onto something. I love this episode. I learned a ton, and I was a little bit wrong about some of my preconceived notions of ACL repair. So I highly, highly, highly encourage you to open your mind a little bit, listen to this episode, and obviously stay tuned for part 2 coming out next week, and check out some of the stuff we've got on social media. Go to Dr. D's Instagram page and check out the progress that his patients are showing. I have never seen someone after ACL reconstruction doing single leg squats to a chair for reps 3 to 4 weeks post-op. And in Dr. D's case, that's kind of the norm, and people are running within a couple months. Meanwhile, with reconstruction, we're usually seeing people run 3 to 4 months post instead of 1 to 2. So I'm a huge fan of what Dr. D is doing. Highly recommend you give this episode a listen and stay tuned for next week, and highly recommend you check him out on Instagram. Enjoy. Dr. D, welcome to the podcast. I'm super excited to work with you today, and I'm super excited to hear more about Save the ACL.
Hey, thanks for having me. Good to see you.
So for people who might not be familiar with you, maybe they haven't seen you on social media, and maybe they haven't seen all the amazing progress photos and videos that you're posting of your patients, would you mind filling them in a little bit about who you are and what makes you kind of unique in the realm of sports and ortho surgery?
Sure. My name's Greg DiFelice. I am a sports traumatologist, I call myself, because I kind of straddle the fence between sports and trauma. I see kind of a heavy trauma mix of sports injuries. And I always have, because I've always worked near or in a level 1 trauma center. So it's not just simple little football injuries or whatnot, with the standard ACL stuff. It gets a lot worse when people are crashing motorcycles or getting hit by cars and things like that. So anyways, I'm an attending surgeon at the Hospital for Special Surgery in New York City. And I guess people know me the most for an approach to ACL surgery that's different than everybody else. I call it ACL preservation. And it is a treatment algorithm that's based on the tear type and the tissue quality of the ACL after you've injured it. So just to kind of straighten you out a little bit, is the standard treatment for ACL injury, no matter what your age, no matter what the mechanism, no matter how bad it's torn, is to get a reconstruction. That's the gold standard. We've been doing that for 30 or 40 years. And a reconstruction is, for those people out there who don't know, it's when we go into your knee with a little scope, we look inside, and we take out all the torn tissue that you damaged when you injured yourself. So the entire ACL is gone. Now, in order to replace that ACL, we drill a hole in the shin bone, the tibia, and we drill a hole up in the femur, which is the thigh bone, right where the old ACL used to sit. And now we have to put some tissue in there to make a new ACL. And so what do? We rob Peter to pay Paul. We steal some tissue from your body, either the patella tendon or the quad tendon or the hamstring tendon, and we make ourselves a graft that's kind of about the size of the old ACL, and we put it up there in the holes we just made. Now, we lock it in there with some buttons or some screws, and there's one other type of graft you can use. It's called an allograft. That's when we use it apart from a dead person. So sometimes we'll do that too. There's a lot of different scenarios that can play out in this ACL game. Anyways, we lock that graft into position. Now your body has no idea what the heck is going on, right? Your body just knows that a bomb just went off in the knee, And so it starts to heal. And what it's going to do is it's going to recognize that that graft should not be in there. And immediately it's going to call for the body's police and attack it and try and get rid of it. The trouble is it can't get rid of it because it's too big and it's too dense, etc. So essentially what the body does over time is it turns the graft into scar tissue. So in essence, the goal of modern day ACL reconstruction surgery, which is basically all ACL surgery, is to trick the body into making a new ligament out of scar tissue that uses the graft as scaffolding for the scar tissue to form upon. Now, that's kind of in a nutshell what we do now. For the past 30 or so years, we've been working on this. But the trouble is, as we all know, and anybody out there who's had an ACL knows, is that's not an easy road. That recovery is very difficult. There's a significant failure rate out there. There's significant complications that can happen. And it takes people a long time to get back from that injury. In fact, there's some very sobering statistics out there that show that even in some of the highest athletes, the highest quality athletes out there who have ACL surgery, sometimes only 40 to 60% of them ever get back to the level that they competed at before. There's a paper that just came out from the Moon Group, which is a big, huge group of orthopedic surgeons called the Multiple Orthopedic Outcomes Network, and they pool all of their data together. And they just published a paper that looked at the highest level athletes. We use something called the MARC score. It's an activity score. So if you're a person who sits on the couch all day, you score down like a 1. And if you're a person who plays really competitive soccer 5 times a week, then you might score a 16. So they took all the patients from 12 to 16, the highest activity patients. They all had ACL reconstructions, and then they followed them up at 2 years. In fact, there was almost 1,200 patients that they reported on at 2-year follow-up from many different centers and many different surgeons. And what they found was that only 40% of the people who had the surgery ever got back to the same level of activity.
That's pretty shocking stat. Yeah.
That's pretty shocking data. That just came out in the American Journal of Sports Medicine, the highest impact factor journal we have. And it was written by the highest impact group that we have, which is called the Moon Group. So that's pretty sobering stuff. And there's a lot more to the paper. Obviously, that's just a little nugget. But there's also another study probably 3 or 4 years ago, maybe 5, that looked at roughly 350 ACL tears in NFL athletes. Now you figure who's going to have the best chance to come back? An NFL athlete, right? They've got, they have 7 trainers for the 7 days of the week. They're the most supported athletes in the world. And what they showed is that only 60% of the players ever made it back to play again in the NFL. And of the 60% that played, the majority of them played at a significantly reduced output. And by 3 years after the surgery, very few of them were left in the league. So, these are very, very sobering statistics. Now, obviously, the NFL has, there's a lot more at play, because there's a lot of money, a lot of pressure to have the people healthy. So there's different reasons why people drop out. It's not like the everyday average athlete, but it just, goes to show you, not everybody out there who gets an ACL is like Adrian Peterson, who came back and had a Pro Bowl season his first year back after an ACL.
Right.
So I do things differently, So my approach, I have a 3-pronged approach. And like I said, it's based upon how the ligament's torn and not simply if it's torn. So now if you can think of the ACL as a rope that connects your thigh bone to your shin bone, and it keeps your shin bone from sliding forward. So When the athlete goes to run and cut, and sometimes they get hit and sometimes they don't, it's a non-contact. We all know that that's a common theme is you go to cut and your weight's wrong and you hear the dreaded pop, right?
Right.
When that pop happens, your shin bone slides forward because the rope that connects your bones together was overwhelmed by the forces of your body and it just rips. It pops. The trouble with that is that now you're left with a loose knee. The analogy I always use for my patients is a simple one. I tend to use simple analogies. Having an ACL out is kind of like driving a car with a loose tire. Imagine if somebody loosened up several of the lug nuts and now your tire was wobbling. Now, you can still drive a car with a loose tire, but you can't take the turns very fast, right? And if you do, you're going to destroy the tire. And if you just keep driving on it and ignore it, you're not going to get 50,000 miles out of your steel belted radial, right? It's probably going to wear out and go bald at 20 or 25, depending how loose it is. So keeping with that car analogy, the current gold standard treatment for ACLs in the world is basically to replace the tire. It's not to tighten the lug nuts, right?
I like that analogy. I like that.
You got to keep it simple, right? I mean, there's the old philosophy, keep it simple, stupid, right? It's the KISS philosophy in life. And you can understand that. Like, hey, why don't we tighten the lug nuts? Because, well, the whole point is that the ACL, like I said, is a rope. Now, sometimes the rope shreds itself. So you look into the knee and it's just destroyed. It's spaghetti everywhere. And the actual functional tissue, the strands of that rope are completely destroyed right in the mid-substance of the ligament. It's like somebody took a scissors and cut it right in half. And there's no way on God's green earth that you're going to be able to fix that. So we replace it. But the trouble is that sometimes the ACL tears and it simply pops off the bone. Now, when you look in the knee, the entire ligament is sitting there intact, structurally intact, and it's simply detached from the bone. Now, sometimes it's 90% detached, sometimes it's 100% detached, sometimes it's 50% detached, but none of that matters because we only have one treatment option, and that is chop it all out and put a new graft in there. The most morbid approach is our only approach, right? So I came up with my preservation first approach, and it's pretty simple. It follows along the lines and the hope that I'm going to try and do the smallest, least invasive, least morbid, which means injury to the body, right? The least morbid surgery that I can do for the patient that will give them the best chance of having a stable knee. So when people tear it right off the bone, I'll repair it if I can. When people have 75% of the ligament left, I'll repair what I can and then add a graft to it. The benefit of that one is you keep part of your ligament and you reinforce it with another graft, right? So that you get the best of both worlds. And then only as a last resort will I do a reconstruction. And that's if there's no good tissue left, right? So it's a pretty pragmatic approach to surgery. And most of my patients come in and say, well, gosh, that makes sense. You know, if you got one lug nut loose, tighten one lug nut. If you got two or three loose, tighten them all. If those three, if all six of them are loose, or maybe it's five, I can't remember, right? However, if they're all loose and the tire's falling apart, well, then you can replace the tire. You see what I'm saying?
Yeah, I'm following. And it sounds like so far that you're saying that the preservation approach that you're using is most specific for the avulsion type injuries to the ACL, things that where it pops right off the bone, not so much the mid-substance ruptures. Is that correct?
Absolutely. So, and that's been what I've proposed to everyone the entire time I've been talking about this, right? Now, let me just throw a few more things out there so you understand. Like, this isn't something I just thought up yesterday and started, hey, let's just start trying to do this, and then we'll get on some podcasts and everybody will be excited and they'll come see me. I started doing this 15 years ago. And the reason I started doing it was because at that time, very early in my career, I was taking care of a very low socioeconomic group of people. I thought it would be nice and challenging to go up and start a program in a big city hospital in the Bronx. And what I was faced with was a ton of people who don't have any support, right? And who may not understand exactly what you're trying to do for them, and who have to go back to work immediately or they're going to get kicked out of their apartment, right? Who maybe can't afford to take a taxi to go to therapy. You know what I'm talking about.
Yep.
And what you find, and what I found in my first 8 years in practice, was I did reconstructions on everyone. And those patients didn't do as well as the patients when I was at the hospital for special surgery, which is like the mecca for orthopedic surgery in the world, right? Mm-hmm. So when you take that same brand of medicine, the reconstruction, and you do it up for certain populations that may not have as much support, then they weren't doing as well. And so I had a reason to try and look for something new, right? And remember I said I took care of a lot of trauma patients. So I was taking care of huge numbers of people who weren't just tearing their ACL, they were dislocating their knee, they were tearing 3 ligaments, 4 ligaments, bones are sticking out the skin, real bad injuries. And sometimes for those people, tacking a ligament back into place is the best of all worlds, because you don't have to add insult to injury, right?
Right.
And the other thing that was critical for me to develop this technology was that right about that time in the early 2000s, rotator cuff repairs had gone arthroscopic, right? So before that, we used to cut the shoulder open, and then we'd look inside and stitch the cuff back to the bone. But in the early 2000s, we developed a lot of cool technology that allowed us to reach in and use suture passers and pass stitches in without ever opening the shoulder up. And then we had anchors that were developed that allowed us to anchor those stitches down to bone. In essence, a rotator cuff repair is very similar to an ACL repair. When I first started talking about it, I used to call the ACL repair the rotator cuff repair of the knee, because that's all I'm really doing, right? I'm just stitching tissue back to the bone through a few little poke holes.
Right.
But they're very well selected patients, right? They're only the patients who have the ones that popped off the bone. And so back in 2008, when I was starting my private practice, a patient came to me and was referred from a friend, and he was very interested in avoiding the big surgery because he had had a giant surgery on his other knee. So he knew what it was all about. And when I told him, like, hey, I think I can repair your ligament, the MRI, remember MRIs, now the technology with the MRIs was awesome too. So I could see what I wanted to do, which ones I wanted to repair, mm-hmm. without having to go in. And he said, sure, doc, go for it. Because, I went through hell with my other knee, and I'd like to try it, because the way I see it, there's not much downside risk. If it doesn't work, we can always come back and do the other one. And sure enough, he was skiing in 4 months, and he skied probably 30 to 50 days a year and biked 100 miles a week for the past 15 years without any problems.
That's incredible. And I know that's not the only story that you have like that. It seems like almost all of the patients you're sharing on social media are getting back to what they want to do far faster than what I typically see from a soft tissue graft or a BTB graft.
Yeah, you can't even really compare it. The recovery from an ACL repair done correctly for the right person is analogous to the recovery from a knee arthroscopy meniscectomy. You know, most of the patients, and this is all good data, mind you, right? Well, actually, let me roll back for a second before I get into that data, because we started with the first one in 2008.
Yep.
Now think about this. I'm a young doc. This is the first. Nobody's ever even talking about ACL repair at this time. There's one other person in the world who's talking about ACL repair with a different approach that was basically looking at the science by operating on pigs, but we're not going to get into that right now. But no one had ever really talked about, that I know of, had talked really or done many surgeries of looking at an arthroscopic ACL primary repair. Now, there were a few back in the early 90s, but let me throw in the historic real quick so you get the historic why we don't do ACL repair. And that reason is because ACL repair was actually one of the original ways that we tried to treat ACL injuries, right? Back in the 70s and stuff like that, when somebody felt the pop, they would come in, they'd cut the knee open with a 10-inch incision right down the middle. They'd crack it open just like a total knee incision, and they'd try and stitch the ACL back to the bone through drill holes, and they'd tie knots up over the cortex. The trouble is that was the only option they had. So they were trying to stitch together mid-substance tears. They were trying to stitch together ones off the bone. They were trying to, everyone who came in who needed that surgery, which is far fewer people than now because people are more active, everyone got their knee cracked open from the front and they got it stitched back together. And then they were put in a cast up to their hip with their knee flexed at 20 degrees for 2 months. Yes, and if your podcast people could see what you, like I'm looking at you right now, they would have seen your eyes pop out of your head. Yeah, because people know that is absolutely insane. That's like taking a total knee patient and putting them in a cast in flexion for 2 months right after the surgery.
Good luck getting your extension range of motion back.
Yeah, you're dead, right? And the crazy thing is, right, so 100% of the patients who had that surgery were absolutely miserable, and it took them forever to get their range of motion back. Even the doctors were miserable, because when the patients are miserable, the doctors are miserable. Let's be realistic. And right next to them is the therapist, who's even more miserable because they got to work on them, right? So what happened is everybody was miserable 100% of the time, but actually 60% of the patients actually did well. Their knee was stable and they were good. They lived with it. But because everyone was so upset by the experience, and because arthroscopy had just come around and everybody wanted to figure out how to do it arthroscopically, they abandoned the idea that the ACL can heal. The doctors of the time looked at the data and they didn't say, oh, look, 60% heal. Let's figure out what was different about that group. And then we can do repair on that group. And then we can do reconstruction on the 40%. They didn't do that because repair was a miserable procedure. They didn't want to do that, right? And they didn't have the ability at the time with the technology to do an arthroscopic ACL repair. And so what did they do? They abandoned ACL repair. And they said the ACL, the conclusion was, and it was erroneous, they said that the ACL can't heal. And that's what the last 5 generations of doctors have been taught as to why we do a reconstruction for every single patient who comes in who's athletic enough to warrant an ACL. And so the amazing thing is actually they had the data in their hands at the time. It's not that the ACL can't heal, because 60% of them did heal. It's just that only certain types can heal. But that went out the window. And then time went, a couple of people tried to do it arthroscopically. There was one guy who deserves mention. His name is Lanny Johnson. He came up with what's called the Lanny Johnson staple. And he what he did was he said, some of these ones that are long, especially oftentimes in skiers, sometimes you can just staple it back to the bone. And you can do that arthroscopically because you can sneak a little staple in through the hole. You don't have to cut the knee wide open, right? And so Lanny Johnson had a little group of people for a little while who did well if they were chosen right. But the overwhelming majority of doctors said, we're going to reconstruction for everybody. It's more predictable. They had a bad taste in their mouth because of the previous experiences with the cast and the open procedure, and ACL repair. The whole idea just was dead. And it was dead for 20 years until I came out and said, hey, why don't we repair the ACL? Or I can do it arthroscopically. Check this out. And you can imagine the warm reception that I got from my colleagues.
Everyone was right on board with it, I'm sure.
Oh yeah, sure. Because orthopedic surgeons aren't very firm in their convictions.
It's funny you bring up the topic of ACL healing, because just earlier this year, I think it was, there was a study published in the British Journal of Sports Med, I believe it was, that showed MRI confirmed evidence of ACL healing, and I think 1 in 3 individuals without even going a surgical route. So it's one of those things. It's like, it's mind-blowing to think that the ligament that we thought for the longest time could not heal at all is now showing signs of regenerative properties, for lack of a better way to put it.
Yeah, well, I'm gonna educate you a little bit on that.
Okay.
The fact is that there is a tremendous variety of ACL tears, right? Of how
Right.
you tear it, of where you tear it, of what else you tear at the same time, of how loose your knee is at a baseline, right? And a lot of these things get lost in the shuffle, right? Like if you just take a big, huge pool of people and it says ACL tear, right? Some of them strained their ligament, but it didn't really blow apart. And they're not too loose and they're okay. And when you look at it on MRI, in the beginning, it's has a lot of fluid signal in it, and then it just goes away because they didn't really explode their ligament, right? And there's some people who tear part of it, like 30% of the fibers, and because there's 70% are sitting there, they heal back into place. Some people even rip the whole damn thing off the wall, but it doesn't pull away, and it just sits there and scars back. Some people tear their ACL and it falls over onto the PCL and it scars to the PCL, and their knee becomes stable because it's scarred to the PCL. All of these people are ones that we talk about as, oh, their ACL healed, but it didn't. Some of them weren't really torn. Some of them, they're healed, but they're not quite normal. So there's a huge morass in that pot of stew, right? It is a dark and murky water.
Right.
And and somebody wants to come out with a paper that says, oh, look, these people healed, right? But they don't document how loose their knee is. And usually they don't. I'm not familiar with the exact paper you're talking about. They don't. So what would be really evident was like, okay, if it healed, does that mean your knee is as stable as your other knee when you measure it with a lock meter? And so that's the difference. Is a lot of these papers don't talk about how loose your knee is. In the past, they talk about people. There's 3 groups, right? Copers, adapters, and non-copers, right? You've heard that. Everybody's That's like old school teaching. But the thing is my point is that they probably, what would be a great way to do that study is to look at the same group of people and see how lax their knee is. Because the people who were probably copers were the ones who didn't have very loose knees. And the ones who were non-copers were the ones who destroyed their knees and were super sloppy knees. Right? So I'm not so sure if it's a mental power, I can cope and therefore I'm more, I'm not sure if that's the thing, or if it's just how loose your damn tire is, right? How many lug nuts are loose?
Right.
And if you got 5 lug nuts loose, you're not going to be able to cope. Right? And if you got one lug nut half loose, you're going to be able to cope. But they're all labeled as ACL tears.
Right,
You see what I'm
right.
saying?
Yeah, it's more of a question of what quantifies healing and also what state were you in the first place.
Some
And
people have very loose knees to begin with, right?
yeah,
And so we all know that, some of these kids come in, they can bend their knee backwards 30 degrees, and you're like, oh my gosh, how did you run in the first place before you hurt your ACL, right?
right.
So
So walk me through, based on your own experience and your research on the ACL repair work that you've been doing, what's the typical patient coming into you from a presentation like? And if you wouldn't mind, I'd love to hear a little bit about what kind of injuries in addition to ACL you're seeing and how the repair works with, say, like someone who has a proximal avulsion of the ACL and maybe a meniscus tear or an MCL tear or some of the other
sure,
injuries in the knee at the same time.
sure. So I'm gonna go roll back a little bit, and I'm gonna continue the story. Obviously, I've been through this quite a bit, and it makes it easier to tell the story to people that way. So, did the first one in 2008. I knew I was onto something when I left the operating room that day because it just makes sense, right? If the tissue's sitting there, I mean, let's be realistic. An ACL reconstruction surgery is a surgery that's main goal is to put tissue where there isn't tissue, right? So you lost your ACL, and now we put tissue in there so it can become a new ACL. Well, it always made me scratch my head is why are we putting new tissue in there if the old tissue looks pretty damn good, right? And why can't we just attach it rather than take it all out? So, anyways, 2008, we did our first one. I was really excited. The guy healed quick. And back then, I didn't do as many ACLs. My practice was very varied. And it took me 5 years to collect 20 patients, right? So I went really slow and I meticulously, picked them out. And we did great. And it took, in order to publish, you have to have 2-year follow-up. And so eventually, by 2012, I had 2-year follow-up on enough patients that I could go out and talk about this and share my data, and et cetera. So I went out to the first conference that would have me, which is basically a startup conference because they needed people to talk. and that was the only one that would let me on with such a ludicrous, topic, ACL repair. Are you crazy? Who in God's name would be talking about that, right? So sure enough, I got out there and I started sharing my data. I got up. I was pretty nervous, because I knew that I was going against the world. And I got up and I showed that I had 11 patients who had type 1 tears right off the bone, and that 10 out of 11 patients were doing great. And the one patient that wasn't doing great, he got loose, but he really didn't follow any directions at all. He took his brace off, post-op day 2, and, he was a bit of a knucklehead, right? So that wasn't so bad, right? 10 out of 11. And I got up there and I was standing up there all, excited to share my data, and I could hear the crickets in the audience, and I could see the doctors out there whispering to each other, like, did this guy just say ACL repair? Is he crazy? And so sure enough, once I got up there and presented, the hail of arrows came back at me. Didn't you read the old papers? Didn't you learn that, at 5 years, they all fail and none of it works and you can't do this and all that. And I said, okay, well, I just wanted to share my data. And then at 5 years, I presented the same group of people with 5-year follow-up, and actually none of them failed. Now then the big problem was, well, that's a small group of people. I said, okay, well, how about this next paper? Here's 56 patients. And how about this next paper? Here's 113 patients. But it's always something and I've learned over the years that trying to get people to change is unbelievably difficult. Trying to get people to even listen is unbelievably difficult. As human beings, we are comfortable doing things the way we know how to do them, the way we were taught to do them, right? I already told you, 5 generations of orthopedic surgeons were taught that the ACL can't heal, and that's why we reconstruct every single one of them. And the only ones we don't reconstruct are the ones that we treat conservatively because they're not enough of they're athletic enough to need their ACL. And that's the way it goes, right? But in reality, what you and I both know is that there's a lot of gray in between those two endpoints, right? Because there's a lot of people who may not have instability playing soccer because they don't play soccer, but have instability walking around every day. There's people who tear their ACL stepping off a curb. I had one patient who the luggage fell out of the rack in the plane and she fell backwards and tore her ACL. Endless amounts of stories, right? And so it kept rolling on and more people started hearing about it. And what I realized, one of my patients came to me along the way and he said, "Hey, doc, this stuff is so cool. You need to show people." And I said, "Yeah, I know what you're talking about, because when I tell people, they just don't believe me. And what I know is that if you sit in my clinic and you watch the patients, or you come to surgery and see me do the surgery, those people are the ones who quickly believe." And in fact, I've had many surgeons from all over the world fly in to watch me do the surgery. And I say to them, if you're going to come and watch me, you have to come to clinic so that you can see the patients, because you won't believe it if you don't see the patients, right? And why would you? Everything you've learned says it doesn't work. And sure enough, all over the world, people are starting to believe in this stuff and to do it because they've seen it. And what I did was my patient told me, he said, "Doc, why don't you go on Instagram and Facebook?" And I'm like, "What are you talking about? Social media?" I had no idea. It was 2015 or 14, somewhere in there. No doctors in their right mind would go on social media. Nobody did it at that
You're
time.
probably more of a MySpace guy anyways, right?
I have no idea what that is. But, sorry, dude. Come on. I got a lot more gray hair than you do. So whatever, yeah, that joke went right over my head. So anyways, we put up the Facebook and Instagram so I could show other people just how quickly these patients got better. And I was hoping that maybe they would believe that, holy crow, look at that, that's amazing. And then more people would start to kind of see and understand what I knew from a personal experience. But in reality, all it did was piss off all the doctors at my hospital, because nobody used social media at that point, right? And so I was the first one to break that barrier, or one of the very early ones. I don't want to, trust me, I'm not trying to take credit for something like, so I was one of the early ones to adopt into social media, and this was a massively controversial topic, right? Going against the grain. So anyways, it kept rolling. And what happens with these ACL patients is they recover so fast that they start spreading like wildfire, because the therapist who takes care of them tells 10 of his friends or her friends, right? And the people who's in their family, and it just spreads really quickly. Like if you have an ACL reconstruction and you're miserable and you have to work really hard and it takes you forever to get back, well, that's pretty typical, right? That the story you're telling doesn't make you unique. So nobody really wants to hear it. But when you tell somebody that I had an ACL and I didn't take any pain medicine, and I was walking within days, I had full range of motion in a week or two, I was running at 6 weeks, and I was back in the gym like nothing happened in 3 months, and I skied at 4 months. People listen, right? And when you're back in the office a week after you had your ACL repaired, and the entire office was like, "I thought you were going to get ACL surgery," because half the office had ACL surgery because they all blew their knee playing beer league softball, right? It starts to spread.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.